members of the public may wish to follow at London Assembly on Twitter and use the hashtag AssemblyHealth for this meeting. May I remind participants to make sure their devices are on silent, and the main item on the agenda today is our discussion on the GLA Group Public Health Unit. However, we have a few short items of business first for the committee. Can I now ask our clerk, Diane Richards, to confirm any apologies for today's meeting?
Thank you, Chair. Apologies have been received from Assembly Member Dr. Ankur Sahota.
Thank you. And can we note the list of offices held by Assembly members, and can I also ask Assembly members if they have any disclosable pecuniary interests in any specific items listed on today's agenda? No. Can we confirm the minutes of the meeting held on the 6th of October 2022? Thank you. And can we note the completed and outstanding actions arising from our previous meeting and the additional correspondence that has been received?
Noted.
Thank you. And that brings us today to our main item, and I'd like to extend a warm welcome to all of our guests today joining us to discuss the GLA Group Public Health Unit. We've got Vicky Hobart, who is the Group Director of Public Health and the Deputy Statutory Health Advisor for the GLA. Dr. Tom Coffey, OBE, who is the Mayoral Health Advisor, and I understand you have to leave at 11 as well. We'll try and tie in a comfort break with that so it's not disrupting the meeting too much. Bhogal, who's the Assistant Director for Health, Education and Youth at the GLA. Farrah Hart, who is the Consultant in Public Health at the GLA Group Public Health Unit, and Will Balakrishnan, the Director of Commissioning and Partnership at MOPAC, the Mayor's Office for Policing and Crime. To set the context for our meeting, the Public Health Unit will begin with a short presentation, so we await your presentation, but thank you all for joining us today.
Thank you, Chair. So Jazz and I are going to just flick through some slides just to give some context to the setting up of the unit. Hugely exciting to be here. It's about a year in the making of the GLA Collaboration Board programme that set this project in train, and we've been mobilising the unit since April, so it's very exciting to be here to talk about where we've got to. It's timely, given we're coming out of the pandemic. We're also dealing with increased pressures around cost of living that will put pressure on Londoners, and we have a health and care system that's working very hard to catch up with the backlog as well as emerging needs. So it's very timely that we're working in this different way. It's also going to be hopefully put us in a good position to prepare for the future, both around an ageing population with more long-term conditions, as well as some of the pressures that we anticipate around climate and health. So moving to the slide deck, which hopefully colleagues can see on the screen as well. The core foundation for the GLA Group really is around health and equalities, and that's the bit that's in the legislation around the health and equalities strategy. We've got a little chart here. Each of those dots represents a very small area of London, each one being about 7,500 residents. They're called middle layer super output areas. And really this is a graph for London that was used in the National Health and Equalities Strategy, really, which is showing that this social gradient in health is still alive and well in London. We have a big difference in life expectancy. So for children born today, how long can they expect to live between these small areas in London? And at an average level, we've got a difference of about four and a half years for men and about 6.3 years for women. But that difference is even greater for those when you look at the extremes of this chart, between the most deprived and the least deprived areas. And that gap's even bigger for healthy life expectancy. How long can people expect to live without disability, without limiting long-term illness? And in some boroughs, you're looking at some of the population expecting to live about 25% of their life with a disability. And a lot of that is preventable. And really that's what this function is about. That's the golden thread, really, is about how we eat into that, into those avoidable, systemic, unfair differences in people's health. If we move to the next slide. We need to bring that to life. The GLA is a strategic authority. Colleagues will remember the Jubilee line and some work that was done, Lives on the Line, that looked at the fall in life expectancy as you went east along the Jubilee line. That was opened in 1999. We've done a similar piece of work just to look at whether we have that gradient on areas of the New Elizabeth line, just again to try and bring this challenge to life, and we do. The job of the public health system is to help partners understand, well, what do we do about that? Those social gradients exist. We can describe them. What do we do about them? We need to understand the population, their health status, what determines their health, the health behaviours that contribute to this, causes of illness and death, as well as the role of the health and care system. And we've actually got a slide deck coming forward soon that will bring those health inequalities to life a bit, looking at the data for London, and we're happy to share that with the Health Committee when that is developed. I'll hand over to Jazz now to talk a little bit about the strategic context. Jazz.
So the ambition all along in establishing the new public health unit was always about having a single voice for health and wellbeing for London and the Mayor. And the creation of the new unit is complementary to the existing function that we have already in the GLA through the health and wellbeing team that sits in my unit that covers health, children and young Londoners. And the role of the existing team, the health and wellbeing team that sits in my unit, is very much about supporting the Mayor in devising his health and wellbeing policy, so specifically and ostensibly about what the Mayor wants to do around driving forward action, specifically around health and care issues, working closely with the health and care partners that we operate with and operating as part of the health and care leadership community for London, and being very kind of focused on those priorities for Londoners that we've identified through the communication and the relationship we have with Londoners, and through understanding those needs. So in particular, continuing the focus around delivering the health inequality strategy and working hand in glove with the new unit around how we do that operationally through the remit of the Mayor across the GLA Group, and that's clearly work that the new public health unit focuses on. And our contribution to that will be about how do we engage the wider health and care system to also contribute to the delivery of the Mayor's health inequality strategy. In addition, we are the team that's responsible for delivering the key priorities under the mission, so the work around increasing the capability of communities in supporting their own mental health and building resilience, and tackling the work, taking forward the work around healthy place, healthy weight, and in particular delivery of our key flagship programmes such as delivery of super zones and the work supporting healthy schools and healthy early years. These are all complementary areas of work, and the advice and the capacity and the capability of the public health unit is still something that we value and want to rely on, but actually the capability and capacity of and the skills and knowledge and relationships that the existing health and wellbeing team has are still there. And I think the kind of relationships that we have with our health and care partners, we do together. We operate and work as part of that public health forum collectively. And then the Group Public Health Unit, as Vicky's described, is very much around supporting the wider offer of the Mayor through the entirety of the City Hall organisations, and looking at what part they can play in improving health outcomes. And we see that time and again in different ways, and there'll be lots of examples through this presentation and through the discussion. And so the kind of key strategic kind of context areas for the work that both our units are operating within is thinking around how do we restore confidence in the city amongst the public post-pandemic, and really support Londoners to use London again and for London to get back to full running. We're really focusing in on those partnerships that we have. So through our health and care partnerships, we are partners towards delivering the health and care vision for London. And that health and care vision has prioritised a number of themes, such as around tackling the health impacts of homelessness, tackling childhood obesity, all the way through to understanding what are we doing to support Londoners who need end-of-life care. So there's a whole array of activities and priorities that have been identified that can take or that require action at a regional level. This is not about replicating what goes on in the NHS or in local authorities. This is about those things that we can do, and we need to continue to play a big part in that. A part of that isn't just about what the Mayor wants to contribute specifically around health, but also about what we would in terms of the GLA, but also in taking that massive potential of those other organisations and those other areas of priority he has a remit for, and maximising where we can have a health in all policies impact. And in particular thinking around delivering, the big focus being around addressing those health inequalities that we see affecting Londoners day in, day out. And targeting that activity, particularly, for example, some of the new areas of work we've just taken on around that we really want to focus in looking at race disparities in health outcomes and the double whammy of the effect of social inequity as well as race inequity, and understanding what impacts they have around health and well-being. And really working closely together as units around supporting London's resilience. And as we've seen in the pandemic, the existence of a public health function somewhere within the GLA meant that we were slightly more on the front foot than we would have been. But actually, it took time for us to really engage that public health capability through some of the wider organisations, and the existence of the new unit will really make sure that we are absolutely in the right place to take that work forward. And so I explained a bit more about our unit and how they work closely together, and Vicky will take it on from here.
Thank you, Jazz. So we're a strategic function. We're in the Communities and Skills Directorate in the GLA. We're hosted there. We're a shared service, so we have shared service agreements and financial agreements between the GLA with Transport for London, MOPAC and the VRU, the London Fire Commissioner and OPDC. But we also work, the collaboration board, remember, includes the Metropolitan Police, the London Ambulance Service, the Olympic Park Development Authority, and they're part of the forum. So there is wider reach around collaboration across the full span of the group. But these are the organisations in the shared service agreement. So we will provide a lot of public health specialist skill, but we'll help to broker in very specialist skills where they're required, and we work as part of the wider system, including Directors of Public Health in councils, OHID, UXA, and in the NHS. Core focus is health in all policies and health resilience, bringing that specialist expertise to bear, and, as Gladys described, aligned but separate to the work of the other unit. What we're trying to achieve through this, the vision, is that the kind of work we do is about people keeping people safe, so threats to health, whether that be infectious diseases, environmental hazards, preventing ill health by keeping people well and tackling those causes of ill health, and narrowing health inequalities, which is the key duty of the Greater London Authority. Well, what benefits is this going to bring? So going into this, through this collaboration and the various sprints, what were the benefits that we all wanted to realise through the collaboration and the unit to support that? So it's the consistency of the public health advice and the relative independence of that to support the different entities in the group, but also resilience. So including a lot of the outcomes we're trying to look at take a long time to shift and to move. So there's something about capacity, but also organisational memory, continuity, particularly between different political administrations, political terms, national electoral processes, etc. So giving us more resilience. It gives us better board level influence and support, aligned governance, and a way of structured working between the different organisations. And also this idea of a centre of excellence. And that excellence can be around training in public health, and we'll talk about, probably have an opportunity to talk about that a bit later, but as well as academic collaborations and policy collaborations, whether that be with other cities in the UK or different academic departments. So the unit itself, we've got a structure chart which I've shared with the committee previously. Essentially, we're organised into areas of portfolio working. So if you imagine, we're bringing together where are the big health outcomes, where are the big levers of the GLA Group organisations, where are there opportunities to intervene, like where is there evidence that we should be doing things or could be doing things differently or better. So it's organised through portfolios, and those are led by public health specialists. So we have 5 portfolios, one focused on housing and inclusion health to vulnerable adults, another focused on community safety and vulnerable young people, and we've got Farrah and Will today that will bring that portfolio to life a bit. We've got one on transport and air quality. Your last committee, we were looking at active travel. That would be an example of the work that Katie Hunter's doing. And then also slightly newer portfolios around economy, children and culture, and planning and environment. A number of those roles, the posts have moved over, and in creating it, we have effectively established 4 new roles, and they provided some project and programme capacity, as well as some doers, so policy and strategy officers that can actually take through some of the work that we want to take forward through the different portfolios. We bring a range of skills to the table. As I've said, some of those are skills that the people who are trained and are specialists and have professional registration. So the inner ring here, 1 to 6, relates to the professional competencies that public health specialists need through their registration. And then on the outer ring, we see some of the kind of networks and collaborations that hopefully the function can bring to the table, whether that be collaboration with the M10 areas in the work they want to do on health and equalities, whether it be academic collaborations or the trainees that we bring in and support on their placements in the GLA, as well as the professional networks. So working with the Directors of Public Health in local government, working with OHID, Department of Health, the Chief Medical Officers, and also working with the NHS. So objectives for the year ahead, I've shared with the committee previously. This is what we've been focusing on in this kind of mobilisation year, recruiting to the unit, establishing the unit culture, progressing existing commitments. So we didn't start with a blank sheet. There are existing commitments and pieces of work, including resilience, COVID pandemic. It's been a very busy time, as you can imagine, the past 2 years, 2.5 years. We've got a view to the evidence base for future strategies for the city. And we've got a view to where are the untapped opportunities there are around health gain and health inequalities. Jez.
The unit corresponds with the role of the what's called the Health, Children and Young Londoners unit. And it's not, and to be clear, focus around health doesn't just sit in structurally what is called the health and wellbeing team, and we'll come on in a moment to the structure slide. Actually, there's kind of health activity happening on what's called the Children and Young Londoners team, where they're taking a big focus around child health and some of the child health programmes that we're delivering. But I've run through a few of some of the key priorities for the Health, Children and Young Londoners unit, but they're primarily, as you can see here, a range of priorities that cut across not just health, but across the wider work that we're doing around children and young Londoners' outcomes. So in particular, the focus is, so I've mentioned the ones that are specifically about health, but the way in which we're doing that differs quite a lot to how we were when we were the health, education and youth team. So the big focus there was always about big, massive grants delivery of programmes. This is much more strategic now. We've moved to a much more strategic way of working, and one that's kind of focused on delivering. We're still delivering those flagship programmes, smaller in number, with greater impact and spread, but looking at what those key outcomes could be across those priorities in our portfolio. And then championing, challenging and collaborating with partners and that wider health and care system in particular across the portfolio of activity. So now with the conversations we're having now with, for example, the NHS around child health are very different to the ones that we would have previously. And these are areas that we all know have suffered greatly as a result of the pandemic. And then amplifying the Mayor's voice to advocate for Londoners' needs across our portfolio, being able to talk directly to Londoners to support them in improving their own health outcomes, and looking at those focusing some of our attention on those communities who suffer the poorest outcomes. So the unit looks like this, and I think kind of it's without a pointer, it's hard to point out to you. Sorry, there's a if you're reading the slide from left to right. The third column, the 3 staff there, that's the team that also supports the new public health unit. And that's our comms, campaigns and insights function. And that's very much around us needing, we want to be able to make sure that that is the place where we're maximising our one voice for health approach. And that's so the sharing of that team and making sure that we're investing in a common team there. It's the column that begins with Senior Manager for Campaigns and Insights, as you're running in from the left-hand side. That team works, as I say, across Vicky's and our unit, and they and the arrangement for doing that is really seamless. It's working very well right now already, and actually the opportunity for that team then to work with the campaigns and insights teams across the wider GLA group is already being established. So we're already finding our feet there. And then, like I say, health is kind of something that we're looking at across the activity of this team. In this unit, we also deliver the Mayor's priorities around the New Deal for Young People. A big component of that work is around supporting young Londoners with their mental well-being. And a lot of the activity that we're doing commonly across the activity of this unit is around mental health, for example. So there's a much more kind of clear matrix way of working that really tallies and feeds in to the support that the public health team are able to give us. Hand back over to Vicky.
Thank you. So just to very quickly touch on the sort of where the mandate and the authorisation comes for this way of working. You'll be obviously familiar with the GLA Act. Unfortunately, Professor Fenton couldn't be here today. He is the Mayor's statutory health advisor, and that's kind of built into the legislation in terms of how the GLA operates. And I perform the role of Deputy Statutory Advisor. So I am employed by OHID, seconded into the GLA, which reflects that legislation. The Civil Contingencies Act responsibilities, again, some of those sit with the Mayor and the GLA, and that's where the health resilience support that we provide can play in, working with AXA and colleagues. A number of these others you'll be familiar with. I did just want to draw out at the end in terms of, I guess, the kind of authorisation environment that we're in is an element of the kind of professional relationships that we hold. So one is with the Directors of Public Health. So my role is not exactly equivalent to a Director of Public Health role in a local authority. Health and Social Care Act 2013 sets out a range of requirements for those in those roles, but we did look very closely at the way in which they worked in designing how this unit and the functions would work in the Greater London Authority. But this is innovative because there isn't an equivalence anywhere else in other regions. We also looked at what Manchester were doing, West Midlands, etc., and that may be something that you want to touch on later in the meeting. And then in terms of public health professional registration, just to explain that, so public health professional registration is something that people follow a kind of 5-year post-grad training programme, and it's open to medics and non-medics. They are professionally registered either with the General Medical Council or the UK Public Health Register. And one of the most exciting things is we've become accredited back as a training programme for people on that route to specialist registration. Those are our specialist registrars in public health, and you may have come across them working on a number of projects. They come and work in the GLA. They're employed by the training programme, but we host them in the GLA. We've had over 16 of them joining us since 2018. So being a training location is really important and adds a huge amount of value, I would say, to the GLA group. And it's a very, very popular placement. They get a lot out of coming to the GLA, so it's very much a win-win. Next slide. So committee will be aware of the forum. So in governance terms, where does the priorities from the unit come? We've established for the first time this strategic forum. It's chaired by Tom Coffey and Kevin Fenton, brings together the group, those that are in the shared service agreement, but also the Metropolitan Police, the Ambulance Service, the Olympic Park, as I said. And it is an enabling network. The governance still sits with those individual organisations and their boards and their governance, but it's a very, very exciting development to have people around the table talking about those public health outcomes. And I just want to thank the committee and the chair for being observing members of that and being able to contribute, and hopefully that will help to support the way in which we support the Assembly going forward as well. Finally, we've shared some slides in practical terms. How do we work together as units? I won't go through those bullet points, but it just brings to life a little bit how Jazz and I are bringing the units together. We do that through joint team meetings, through joint management meetings. We have distinct budgets and delegations, but we do a lot together around things like learning and development, looking at health policy and strategy. So behind the scenes, there's a lot of integration in how we work. I'll wrap up there. And thank you very much. Again, exciting opportunity. I think it positions us well for now, but also into the future. Thank you.
Thank you. And I think also some of the issues that you went into actually will go into further detail in the questioning as well. Thank you for the presentation and the very helpful overview to set the scene. So my first question, actually, I'm going to start off by asking this question to Dr. Tom Coffey around the rationale. And can you explain a bit more about the rationale for creating the GLA Group Public Health Unit, and how is it expected to add value across the whole GLA Group, do you feel?
Thank you, Kripesh. I'm a great believer in evidence-based medicine and evidence-based policy, and therefore, trying to scan the horizon scan the evidence regarding how to improve the health of a city. And I suppose the 3 or 4 papers which I looked at was very much Sir Michael Marmot, looking at the Marmot Report, David Buick, who is working for the King's Fund, doing lots of work about health and all policies. And then also, the thing I suppose closer to home for me is the WHO, which looked at social determinants of health. And in fact, so the health outcomes aren't determined mainly by what I do and what clinicians do. It's by their social determinants. 55% of health outcomes are determined by non-clinical services. And therefore, if we want to improve the health of Londoners, It's not about improving health services alone. It's about improving health interventions which can explore the social determinants of health. And that's where the public health approach comes from. Secondly, in the past, we've probably been very opportunistic in our approach. So we've looked at, say, an intervention, be it the ad ban on a TfL network, as an opportunity to improve the health of Londoners and address health inequalities. But the public health unit will make that approach a much more systematic approach. So we're embedding in every single directorate and the wider GLA family, TfL, Fire Brigade, the police service, and also the Common Development, public health expertise, so it's a systematic approach. Also, when I looked at some of the work that we need to do for the manifesto commitments and delivering the manifesto, a lot of it is about addressing social determinants of health regarding green spaces to improve health, regarding rough sleeping and poor health outcomes. So therefore, and also the key policy was Sadiq was asking, we want to do a health and all policy approach. And therefore the evidence to me points to the development of the public health unit to have a systematic approach to ensuring health concerns are addressed in the GLA and the wider GLA family based on the evidence that I've indicated.
Just sort of picking on that and taking a practical example. So if I was to, so everyone's sort of concerned about the twindemic around flu and COVID, and especially Londoners who aren't eligible but haven't yet taken up their vaccine. So in sort of practical terms, how do you feel the unit will help to deliver those outcomes on a practical level?
Okay. So the public health approach is very much about evidence gathering, data analysis, and also working with our communities. So what we found very much in the COVID vaccination campaign, London initially was always a bit behind the rest of the country. There was some real reticence about taking up the vaccine, and the same in the influenza jab as well. But using public health analysis and expertise, working with our communities, trying to understand what are the barriers and obstacles, and therefore how do we design the systems with the NHS to improve the delivery. So rather than saying, oh, just come to your GP and have your vaccine, we realised that we really had to make sure we reached out to our community. We had to build trust first before people accepted an innovative vaccine as a way of combating COVID. So the colleagues in my public health team work very much with Debbie Weeks-Bernard. With her team, have got quite a large community network about how we deal with the reticence about vaccination and how we increase its delivery. And also what's really important is not to lose the lessons of COVID, because London often is also behind the rest of the country in other vaccination campaigns, not just influenza, but also some childhood vaccination campaigns. And how can we use what we learned via our public health expertise in increasing the uptake of COVID to make that also run into how we improve childhood vaccination and influenza? Because the twindemic, as you mentioned, really will be addressed by making sure that as many Londoners as possible are vaccinated against these two conditions.
And in terms of value across the whole GLA group, and maybe I'll ask Will to come in on this. So in terms of value to the whole GLA group, maybe touching on your perspective from MOPAC, how is the GLA Public Health Unit adding value to your work as well?
Yeah, absolutely. Well, I mean, there are three big strategies in my professional life: the Mayor's Police and Crime Plan, the Mayor's Violence Against Women and Girls strategy, and the Mayor's Domestic Abuse Safe Accommodation strategy. And in all three of those documents, I think we can see the fingerprints of the public health team's input and a kind of maximalist approach to how we deploy public health approaches to meet the outcomes that are in those strategies. I mean, I can talk at length about this. I don't know how much you'd like to know, but in terms of, value for money, we actually make what I would consider quite a relatively small contribution to the public health unit. And I think the value we get back from that is immeasurable. Clearly, public health as an approach, but also specifically our work with the NHS is something, we'll all know the NHS is a big beast and it is hard to navigate. And the geographies are always different and don't always match the other local delivery. I think having a unit which can provide us with both the evidence, both the connections, both the networks into that wider beast, as well as providing us with a real policy underpinning to some of the work we're doing, I think has proved really invaluable. In the past, we would have had to have relied on, for example, in NHS London, there's a health and justice team. You know, they're quite a small sliver of the health economy. And whilst there's some brilliant colleagues in that unit, and I still talk to them all the time, that is such a small portion and such a kind of narrow tranche of the work we need to do. So hopefully you've seen those strategies that I mentioned. You'll notice the public health input in them. You'll notice the approach, and that sort of serves as a good bit of evidence as to how the unit has changed the way we're working in MOPAC and how we're seeking to achieve the Mayor's outcomes and objectives in those three strategies.
Thanks. And so turning to Vicky now, so you mentioned that this unit represents a unique approach and is not replicated elsewhere in the UK, around the country, but you also referred to Manchester as an area you were looking at in terms of seeing how we can improve as a city looking at these issues. So can you point towards other parts of the UK that you're looking at? You can refer to Manchester as well, and what kind of improvements you feel can be made in London based on the example you've cited, and whether also you've been looking at examples from anywhere else in the world.
Thank you, Chair. So the devolution arrangements across England are different. So the arrangements for public health input are going to vary and will continue to vary. So I don't think there will ever be a complete blueprint. We work closely with particularly West Midlands and Manchester. We put in a bid to the Health Foundation 3 years ago, recognising that a number of cities were reaching out to London to understand what was happening around approaches to violence reduction, approaches to childhood obesity, for example, and other city regions with mayors, directly elected mayors, wanting to understand what roles we could play, how best to support those politically led entities. Manchester had a very kind of well-known health and care devolution agreement. It was also a single integrated care system, SDP, integrated care system. There's a lot of learning from them around their approach to population health strategies, and how the combined authority works with the health and care system around agreed priorities. So they, for example, did a lot on school readiness, would be an example. The landscape we're working with London is a lot more complex. The devolution arrangements are different, and we have 5 integrated care systems in London. So it's not directly translatable. But there is a lot of granular learning between officers around how that gets taken forward. West Midlands, again, is set up in a different way. They don't have the benefits of coterminosity that Manchester has as a combined authority, but they're doing a lot around inclusive growth. They've done a lot around work and health. And again, lots of granular learning there, where I think they've been working with us on, well, how do you bring together the Public Health England / OHID function with what directors of public health are doing in the patch, with what the combined authority wants to do under the leadership of their mayor, Andy Street. So officers have been collaborating. I think I've shared a link, and I can share again, of that project. There was an appreciative inquiry approach that we developed, which was helping to tease out at a granular level, how do you take forward work on health inequalities? What are the key ingredients to that? Recognising that will have to be led in those places, in those regions, with those local authorities, with those voluntary sector community organisations, and based on what the priority outcomes are for those populations.
Okay, yep, thank you. And in terms of external stakeholders and the setting up of the unit as well, and the restructure, what engagement was there with external stakeholders about the restructure, including OHID and local authorities as well?
So some of the key stakeholders in taking this forward, one was the Association of Directors of Public Health, and the other was the Office of Health Improvement and Disparities, and particularly Professor Fenton's role. So we were very, very keen that this unit did not create confusion between what are the responsibilities of a Director of Public Health in each local authority in London. There's a legislative framework for that. I was already a member of their network. I used to chair that network. I was a member of that network. And so we had lots of conversations with members and also the chairs and vice chairs of that network as this was being developed, as well as the National Association. From an OHID perspective, obviously as we were going through the sprint, we were moving through the change programme that moved Public Health England into new arrangements, Office of Health Improvement and Disparities and the UK Health Security Agency. And again, Professor Fenton and myself engaged in lots of conversations with the DG and the Deputy Chief Medical Officer in OHID around the new arrangements, as well as UXA colleagues around health security. And again, it can be complex to communicate because we're also very keen to explain what we're not doing. So in the GLA, we are not doing occupational health. We're not doing health and safety, for example. We're also not specialists in health protection in the terms of very technical advice on health protection issues. We work with our UXA colleagues. So there are lots of areas of specialism that I hope my team will hold, but it's also being a broker into that specialist advice and where the responsibilities sit in other parts of the system.
Okay, I'm going to move to my colleague, Assemblymember Russell.
Thank you, Chair, and good morning, everybody. I just wanted, before I move on to my actual questions, I just wanted to pick up on when there was the question about UK cities. I was kind of expecting that there might be some discussion about climate risk as something that cities are looking at and thinking about in relation to health. I mean, things like, the kind of temperatures we saw this summer, ambulance call-outs going up, and just, there are huge risks if you have very extreme heat in summer of people being in their flats, overheating, and they're not out and about. You can't see that their health is struggling. So I was just wondering, I'd asked a question actually to the Mayor recently, based on the Lancet countdown from 2022 about there being insufficient climate change adaptation efforts have left health systems vulnerable to climate change related hazards. And the Mayor's answer was that the recently established London Climate and Health Network will be working with the GLA Group Public Health Unit to bring together leaders from across the health and care system to focus on the challenges of climate and public health and to establish a set of priority actions for increased health system resilience. Now, I'm just wanting to know where that sits in the structure. Does that sit with you, Vicky, or does it sit with you, Jazz, or does it sit with both of you? And do you have a timescale for bringing forward your priority actions?
Thank you. So the evidence base around climate adaptations and mitigations has been an important part. It's referenced in the Health and Equality Strategy. There's been lots of good work that's happened in the GLA, for example, the work on care homes, and adaptations that are required there, cool spaces, water fountains, etc. What we've done recently in recognition of the evidence base, the Lancet countdown, etc., is look at from a public health system perspective in London, where the GLA is just one player in that. So that is, yes, myself, my team, we now have a lead consultant that started, Emma O'Connell, and resilience will sit in her portfolio. She'll hold the relationship with the environment team, etc., around this, but with other parts of the system. So with OHID, with Association of Directors of Public Health, with the NHS, starting small, looking at bringing that evidence base about climate and health together for London. And we're working with the Institute of Health Equity, who are pulling together an evidence review for us, supported by a data pack about climate and health. That's one of the sequence of products they're going to be working up. But that group is slightly internal looking at the moment around the bits of the public health system in London coming together, looking at how will we best support the various parts of the system, including the health and care system, on the adaptations that may be required as we go forward to support climate and health.
Do you have a timescale for when you expect to have a kind of set of priority actions?
So the Marmot review and that product we're looking at being published in the next 6 months, and that's like a kind of independent, semi-independent look at that evidence base about climate and health inequalities. In terms of this network's development, I'm more than happy to come back to the committee. It's not, we are working with the other parts of the public health system. I'd be reluctant to say there is a deadline for a particular product because we're not at that stage yet. It's been going 4 months now, 5 months. Yeah. So there will be, with the Institute of Health Equity, a product focused on health inequalities, thinking forward to the health inequality strategy in the London Plan. But in terms of bringing the public health system together to support other parts of the system, that's the element that we're still working through as a sort of network, trying to get the commitments from the different parties.
Thank you. That's reassuring to hear that much detail.
Okay, can I just add a quick addition? So we discussed at the London Health Board a while back air quality and climate change, and very much from the GLA raising this as a significant issue. So the NHS now have their own green plan. They've got a clinical lead, Dr. Joe Savage, to deliver a greener London from the NHS perspective. And so therefore each trust now each hospital has got its own green plan to reduce emissions, reduce increase in temperature, address issues regarding green space. So therefore I'm quite pleased the fact that NHS has kind of risen to the challenge that people like yourself and colleagues have raised. So therefore it is now proper collaboration, and it isn't just the GLA doing it on its own. And I think the wider system now recognises the threats of climate change. We used to think of always the threat of the cold winter. Now it is the threat of the very, very hot summer. Equally, excess deaths occurring in both scenarios.
Thank you. So my next question is just about trying to understand a bit more about why the public health unit is separate from, and I'm going to have to double check what the name of it is, the Health, Children and Young Londoners unit. Sort of why those two have specifically have been separated out.
Thank you. Part of the purpose of establishing, I'll start with the role of the Health, Children and Young Londoners unit is very much kind of within the GLA and focused within the work of what we are doing as an organisation with our partners. The purpose of establishing the new public health unit was about having leadership level capability and competency in public health to work with and through the wider GLA group, so TfL, MOPAC and the other parts of the GLA group, so that they could play their part in being able to deliver their health impacts potentially. The leadership of that needed to be something that felt synonymous with the way in which local authorities work, and as Vicky's described, it's not the same as, but it's aligned with the role of a director of public health in a local authority. And that the gravitas, I think, that a director of public health brings with those skills and capabilities, as well as the essential skills that trained public health consultants bring, is vitally important. I think also going back to the concept of the statutory advisor to the mayor for health, for health, the legislation. So the GLA Act directs the Secretary of State for Health to provide the Mayor of London with a statutory advisor, and the provision in the Act also includes a deputy. And the Act talks explicitly about that statutory advice needing to be provided across the entirety of the Mayor's remit, so including the wider GLA group. And that's a function that needed to be designed and specifically designed so that it was advising everybody, including the Assembly, with the level of expertise and independent expertise, and partial only to the values of a public health community, so impartial in all other ways, and being able to kind of provide that there. Clearly, a group that's appointed by the Mayor's office to provide specific policy kind of support into the mayor's, delivering the mayor's specific priorities around health and well-being needs a different function, which is the reason why they needed to be quite separate.
Okay, so basically Vicky's unit is kind of looking to the public health system and that structure and engaging with that formal public health piece, and your unit is more about delivering the mayor's policies around public health.
Around health and well-being.
Health and well-being.
Yeah, so included in that would be how we're supporting, working alongside and collaborating with the NHS on some common areas of programmes of work. The work that we might be doing with directly supporting local government so that they are able to take about kind of more, so for example the delivery of some of our programmes are very much hand in glove with health service delivery. That is not public health necessarily, although it's, you know, in that wider scheme. The public health concept being much more about taking upstream the interventions that are really going to have an impact at population level.
Then how do you work together to avoid duplication? Sort of how does that work?
So we paid a lot of attention to the design, a lot of staff engagement and involvement in the design of the units and what it meant. The design of the public health unit coincided with some work that Jazz was doing to restructure that team. So it was kind of well thought through, I guess, in essence, and we took our time in doing it. The health inequality strategy is the cornerstone of what we do. That's a statutory duty. It is a very good, arguable, a very good framework, very evidence-based. So that's the kind of cornerstone of what we're doing, and that applies to the group as well as anything else. In practical terms, our units meet regularly together, all of them, and that's about adding value not just in health, but children and young Londoners as well. So we have joint unit meetings, we have occasional joint management meetings as well. There are key elements like learning and development of staff that we're taking forward together. Our approach to EDI would be another example that we're taking forward together, and staff wellbeing activity, because we'd recognise that for staff at different levels in our unit, some of the less formal interaction they have is quite inspirational, and that works both ways. So there are people in my unit that want to understand much more about programme delivery, for example. Colleagues in Jazz's team want to understand more about, whatever evidence-based practice, etc. So there are lots of touch points where the teams come together, but we do have, separate budgets, separate delegations, which I think is important in teasing out the accountability we have for the shared service agreement with the GLA Group organisations. What are we delivering for them and with them? And will also help us navigate kind of potential kind of conflicts of interest if they were to arise.
So, just taking an example of something that's very much in the news at the moment, the case of Awab Ishaq, who died from breathing mould in a cold, damp flat. Where, that's something that and it's a shame Onka's not here because he was on the Environment Committee when we did our report, Keeping Out the Chill, which actually has some very good solutions on damp and mould and actually addressing the housing stock to make these buildings that are prone to condensation and mould fit to live in. But when something like that comes up, we know, any of us who are councillors will have casework going back years of people being told to put a lid on their saucepan, being told not to have long showers, being told not to hang their washing indoors to dry, when actually the problem of the mould and condensation, which is impacting their health, is to do with the structure of the building that they're living in. Where does a conversation about an issue like that sit? Does it sit with children, young people? And what conversations have you had conversations about that case?
Thank you. So, yes, we've had conversations about that case. So the case in and of itself is initial heads up. We would expect probably a prevention of future deaths review in the same way as that we had with Ella Kissy Deborah and the case of air quality, and then that translating into some specific recommendations about actions that different parties need to take. We haven't had that yet. In terms of what has kicked in, Yes, it's a child in this case whose health was impacted. So absolutely, we would work with the Health, Children and Young Londoners unit. We're also docking into the Directors of Public Health, who are wanting to mobilise advice, as you can imagine, with their housing providers, with their housing teams. You know, what advice can be mobilised immediately that can support local strategies, whether that be through housing associations, council accommodation, private rented sector. So my team, it would work as part of that public health network. We have a public health leadership group. We meet every 6 weeks. So we can mobilise very, very quickly around these things to make sure that the latest available evidence is available. America, for example, has done quite a lot of this kind of with post-flooding risk. We're able to link into UCSA, UK Health Security Agency, around evidence that they have, but also what plans they might have in train, existing work that might be in train, as well as the housing team here. And critically for us, it's one thing having a conversation as a public health community, but the value of this is helping the GLA Group play its part in full. And that would be the Children, Health and Young Donors Unit and the relations they have through the Healthy Schools programme, Healthy Early Years programme, etc., if the evidence points to that being an opportunity, but also our housing team. Now, my team, we are new, so we don't necessarily understand yet every single opportunity, every single lever, and there are limits to what the GLA Group can do in any one of these circumstances. So the kind of immediate assessment is understanding what evidence is there, what are the roles and responsibilities, who's wanting to take action, mobilising resources quickly to get the evidence available, and that's happened. So there was a circulation early this week, and my team played into that, working with UCSA colleagues and council colleagues about mould and health, and it would build, for example, on the work the Assembly did, as well as UCSA, coordinating that, bringing it together, getting it out to the front line quickly, and then my team asking the questions, okay, well, what does that mean for the GLA Group? Yeah, and in this case, very much with our housing team colleagues, Health, Children and Young Londoners unit in this case, yeah, but also preparing as a strategic authority for what may come down the line in terms of prevention of future deaths report, recommendations, yeah, and then looking at is there any pre-work we can do? How might we mobilise as and when that happened?
Shall I just add? So just to add, I suppose, on a very practical level, I suppose, when something like that is, there's public attention on something like that, the practical thing that we would do is Vicky and I would simply have a conversation about it first of all and work out the plan. But I mean, this is a very clear case of this needs the public health unit's kind of consideration. They would then do that work. The kind of stuff that my unit would be doing would be thinking about, well, what does that mean for, what do our health and care partners who are interested in child health think about this? Who are the people that are going to, who are the kind of child health voices out there that we're working with, that we're our stakeholders and partners? What's our collective view? What is the position that we would want to be seeing taken? Whilst at the same time, there's a very practical set of kind of what the public health impact here and what those kind of, for example, kind of the reviews and the impact of the work that we would do. But we work so hand in glove. This is the kind of thing that we can very quickly work through and be quite clear as to what how we need to operate between our two units.
Yeah, I'm done. So thank you. But I will send you both the Keeping Out the Chill report from February 2019, because there is a project at Thamesmead where they have retrofitted active ventilation in flats, particularly focused on overcrowded flats where the condensation and mould was worse, and it made those flats in a building that was prone to mould, it stopped the mould from forming. So there are some solutions out there, but it's not a well understood problem, and I think our report was quite helpful.
Thank you. So I'm turning to Assembly Member Best.
Thanks very much. Good morning, everyone. And I just wanted to build quickly on what Assembly Member Russell was saying, because she's making a really important point there. And she did mention, obviously, as councillors, this is something that a lot of us will have seen a lot, those horrific conditions of mould and damp that we know are causing damage to children's breathing. And, of course, that goes hand in glove with having seen those shocking figures recently from the NHS about the number of children admitted to hospital with asthma this year. And I know you will have all read the British Medical Journal's report on that, on the effect of coming out of COVID on asthma, and they drew on a lot of the reasons for that being, and one of the main ones being the self-management that people could have, obviously whilst they're at home, being close to an asthma pump and things like that. They of course drew on pollution, which is something that is talked about a lot, but it's those other factors around housing, self-management of asthma, and because I know the Mayor's focuses on air quality and those things, but I wonder, and it's a genuine question, are all those other elements that play into those asthma triggers being picked up? Because there's clearly a flagship policy here, right? But there's so many other triggers, and the research shows there's so many other things that we need to be looking at. Are the public health unit as focused, or Tom, perhaps can you reassure me, as focused on those other triggers?
Yeah, and only because I've got to leave in 5 or 6 minutes, I wanted to make sure that I covered this. So the answer is definitely yes. So Sadiq, in fact, has asthma himself, and has been involved in the Ask Asthma campaign on a regular basis for the last few years. And regarding the mould which Caroline raised, so when myself and Kevin Fenton have met all the kind of deputy mayors, and when we met with Tom Copley, deputy mayor for housing, we said what was his priority, and it was the quality of the private rented sector. And one of the issues was mould, because just as you get your concerns as councillors, I as a GP have to write so many housing letters when I just see literally mould caked in houses. And whilst it can cause systemic infectious diseases, the biggest cause is triggering asthma. And so therefore this is an issue which the Deputy Mayor of Housing wants to take seriously, to say how do we look at all the various issues regarding the management of asthma, because air quality when you're outside a house, yes, we know is a trigger for asthma, but all the other things regarding compliance with medication, in-house kind of triggers as well. So yeah, it is something that he takes very seriously.
And just to, I know it's a genuine question. I know there's a political agenda to promote the air quality at the moment, but when that release was made by the Mayor, it did seem to pin all those cases on air pollution and the increase in congestion. But there's a really serious point there. You said Tom noticed this. So how can we make sure that people know that this is also a trigger, and this is also something the GLA realises is another factor, and it is addressing as well? How can we push that up the agenda? Because to me, it does seem a bit lost at the moment.
And I guess this almost begs the question of the importance of the public health unit, because what they will do is look for the evidence. And the evidence, as you say, is very clear that asthma has got multiple triggers, and therefore to improve the outcomes for asthma in London, we've got to look at all the triggers. And therefore I would want to work not just with the Environment Deputy Mayor on air quality, but the Housing Deputy Mayor on the quality of housing, the Transport Deputy Mayor and how we make sure we have, healthy, active travel, etc. So therefore, I would want to make sure that the Public Health Unit works across all the various areas to make sure we don't just focus on one single trigger, but all the triggers. And I would hope that's what it will do over the next few years.
Thanks, Tom, and hopefully I can grab you for 5 minutes more then, because I've got a couple more questions before you have to leave. But I want to ask, what is the role of the GLA Group Public Health Unit within London's wider public health system, including with the Office of Health and Disparities and local authorities?
And so you're looking at me, but in fact the answer is probably best coming from Vicky. But so how we make sure we work is that Professor Fenton and myself chair the forum which looks at how we set our priorities and oversight of our work programme. And I would ask they're working hand in hand. So so Kevin Fenton's role, not only as statutory advisor to the Mayor, but also as a Regional Director of Public Health for London, he is very closely linked to all the DPHs of all the boroughs in London. So we want to make sure that not only are we affecting what's happening in the GLA and the wider family, but also the wider public health teams in London, because often lots of our programmes, like Healthy Early Years, is delivered very much by local authority DPHs. So there's that very tight link. Also with UXA, the other part of the public health system, again, Kevin Fenton is our link to that area. So having, Kevin and Vicky and myself, hopefully trying to bring all those parts together. And the forum, which we meet on every couple of months, is the forum, I suppose, whereby we make sure that any work we're doing within the GLA family is completely cognizant of what's happening in OHID and the wider public health system in London.
Thanks. And I know you said it's better to Vicky. Don't worry, Vicky's on my list, but I'm trying to do your time management to go through questions.
Go on, that's fine.
So what engagement have you had with, for example, NHS London Trust and other community health bodies?
Okay, so I meet the NHS regularly, and in essence I meet the medical director, the nursing director, and the director of operations, and the chief exec of the NHS, every few weeks. And what we used to discuss, as you can imagine, a couple of years ago, COVID on a daily basis, on a weekly basis. Now it's very much trying to look at the wider public health system. So the example, which I did give early, so I've met recently with Joe Savage, who's the clinical lead for air quality and for the greener NHS, to make sure that our joint agendas are linked. Also at a recent meeting just about another social determinant of health, which is the income, but London living wage. It's how can we make sure the NHS is a key partner in this? And I'm really pleased to say that by April next year, all 31 trusts in the NHS in London have signed up to become London living wage employees, because the economic and income inequality agenda is also a key determinant of health. I don't want to talk just about air quality. I want to talk about all the social determinants of health, which are housing, income inequality, air quality, etc. So I regularly meet with all my NHS colleagues on these issues.
Thanks. And I guess one of the big engagement things was the public health unit launch, which I was lucky enough to come to. But I wanted to pick up on something you'd said in your introduction at that meeting, where you said to the room of those community leaders in health and from health that you talked about the TfL junk food ad ban and said that had a positive effect in reducing childhood obesity.
Yes. So what the evidence from the London School of Hygiene and Tropical Medicine showed was there was a 6.7% reduction in the calorie intake compared to our control area. And then further academic bodies have tried to use that to estimate forward what would that have as an impact in childhood obesity. So using the evidence from the London School of Hygiene and Tropical Medicine analysis, they've then also predicted the impact on obesity. Now that is a prediction, and isn't something that I would say there is a definite reduction in those causes, but using the evidence that we know that there has been an estimated prediction of childhood obesity reduction.
But if just to deal in not estimations, to deal in the fact, we know that childhood obesity and childhood healthy weight is dropping, and childhood obesity and those overweight is growing in London, actually faster, I believe, than any other region in the UK. And what concerned me was we had a room full of partners, you said that, and the lady next to me wrote a note down, childhood obesity is down, and that's not true. And so, so I just would hope that we could be very clear on what we're talking about there. You're talking about a prediction, but in that meeting said childhood obesity has had a positive impact because of the TfL junk food ad. Now that could be construed as saying it's down, and it's not. It's actually growing in London faster than ever.
And I agree. And I think I was very careful in my choice of words not to say that childhood obesity has reduced in the last 12 months, because the big difference over the last few years has been the COVID pandemic and the way it's changed how children go to school, exercise, and that has had a massive impact. But all I can say is I started my answers an hour ago about saying evidence-based policy. And all I can say is the evidence that we've got so far is that 6.7% reduction in calories, and the evidence from academic journals about a prediction of reducing childhood obesity as a result of that, I think still stands.
Yeah, I mean, we could go into it, but you know where that prediction comes from, right? It relied on putting the chocolate biscuit intake of Londoners going way up here if we didn't introduce it, and coming up to a northern household suddenly over 6 months, as opposed to staying consistent. Yeah. If it had stayed consistent as to where it was before the junk food ad ban, even if it had risen a little bit, it would have shown the junk food ad ban had no effect. So what the study did was it brought that line right up to go in line with northern families, that the control group. So, I mean, I'm not sure still that is as good an indicator as looking at the actual rising at childhood obesity in London. And the other thing that you said in those opening remarks at that public health unit, and I will launch it because it is engagement with all these health bodies. I think it's important. Said that the ULEZ expansion had cross-party support across the Labour and the Tories. You said. I just wonder who you were talking about within the Conservatives.
Okay, so therefore, I talk to all my health colleagues, and for me, you know, I look at health perspectives. So therefore, when I speak to health partners from the Conservative, you know, kind of party, they also recognise the issue regarding air quality having a detrimental effect on people's health.
So who are you talking about? Not, you don't need to give their names, just a job title. So who, I don't know who you're
these are local councillors. Yeah, obviously, as a GP in Wandsworth, I'm not going to name names. You know, I speak regularly with kind of colleagues within the system, and the local councillors there recognise the health benefits of the introduction of, you know, charges to reduce air pollution in London.
I suppose we'd have to put that to Conservative Wandsworth Group because they might have a slightly different opinion than that. But I just, again, it's about that word choice, and that does paint a very different picture to the what's accurate to our group. But thank you. And I've only been drilling in on you ahead of my other questions because I know you got to leave. So thank you, Tom.
Okay, thank you. Thanks for your time. I apologise, I'm going to go and do surgery, but thank you very much.
Thanks.
Thank you.
Did you want to?
I think you should carry on until the end of the section.
Right,
It'll just make it easier. Thank you.
Yeah, thank you. But I'm just going to circle back round to where we were, if that's okay now. And Jazz or Vicky, you might want to answer this quickly, but you talked about working together. Do you foresee there could be any situation where you would have a conflict or you would come to a different solution?
Thank you. I can't foresee an area where we'd have conflict, actually. I think, if anything, it would be about trying to determine what... I suppose the closest we would get would be actually kind of, isn't this an issue for the GLA specifically to solve? Is there something that a mayoral policy position needs to be taken that only we can take or not? I mean, inevitably, that's kind of almost never happens. There is hardly any issue that we're trying to deal with that only one bit of the system, or it can't be just TfL that would be the partner to sort it out. There would always be a working together. So I don't see any issue where we would have nothing to do with each other's work. So, for example, quite a lot of the work around evidence and academic input is something that we want to be a main beneficiary of. But it's the kind of the skill and the relationships and the capability that sits in Vicky's unit. That's what I would be leaning on, for example. So I don't see a scenario where we wouldn't be working in some way together on almost any issue. But the relative roles that we would play would be complementary.
Thanks, Jazz. Just to add for that, I mean, Jazz and I have worked together for a long time. I don't anticipate conflict. We provide advice.
To blows or anything.
We provide advice. It doesn't mean that advice has to be taken. And the advice is to, as we've described, the group, the mayor, the assembly, GLA officers, the group. So there may be occasions where, you know, in judging a range of co-benefits or competing policy objectives, advice isn't followed to the letter. I don't anticipate that resulting in conflict, though. Thanks.
And Vicky, just much the same question I asked Tom. Did you want to say anything about the where the GLA public health unit sits within the framework of other health bodies, and also about engagement?
So I think Tom outlined how we sit with the other kind of statutory agencies. I think it's exciting other devolved regions. So the M10, you know, it was interesting seeing mayors looking throughout the pandemic at what role they could play at the regional level. That's, you know, and devolution, levelling up, that whole agenda is quite exciting and very new. So that's definitely an area of collaboration where I think, and it's not that we can't learn from others, I think we can. So that's still very exciting. In terms of wider stakeholders, our academic partnerships, you know, we've got amazing academic teams in London doing amazing things, supporting globally, nationally and in London. And I think there's a lot more we can do with that. They are very interested in the work that the GLA can do, not just as the GLA, but as the group and in partnership with other bits of the system. So I think that's quite a rich, we've had a lot of very positive feedback around that. I think that's quite a rich area. And then in the same way that other regions are looking at how we collaborate, other cities are, particularly global cities, are interested in how you affect change. Air quality would be an example. Achieving a healthy weight would be another example. Violence reduction. You know, lots of global cities are interested. You know, Bloomberg brings some of that together. WHO brings some of that together. We haven't necessarily been able to engage as much as we'd like in some of that kind of international learning and collaboration. So that's, again, quite an exciting thing about just having that little bit of programme capacity now to help us explore some of that.
Thanks. It's something I'd definitely like to ask more questions about, but I think we need to run on now. So and what is the role of the GLA Group Public Health Forum expected to play in the development and objectives of the Public Health Unit?
So we took quite a lot of legal advice in setting this up. TfL lawyers fantastically helpful in teasing that out. The governance still sits with the individual organisations. They make their own decisions. So it's not a decision-making board. It's not directing resources in each of those organisations. We do this through a very detailed shared service agreement. And what my aspiration is, and I think we've had 2 meetings now. They've been, you know, really well attended, quite lively. And the aim is that they will help us to prioritise in the sense of how do we use this resource to best effect. And some of that is a two-way thing. So while it's them helping us prioritise, it's also us helping them tease out what they can achieve, want to achieve. And I think this is this balance between, as we go forward, building this sense of this is where the big public health opportunities are. This is where we can make a difference to Londoners, as well as where are there opportunities to do some things, either because of, you know, national government policy shifts or moves or opens up a new opportunity, or because particular organisations decide, well, we want to collaborate on this thing. An example, I don't know, might be staff health and well-being. If you think of how many people work across fire, transport and police, and the importance of staff well-being, again, that may be an area where they want to look at, you know, health inequalities within their workforce. We're not at that stage yet. So what the focus so far has been conversations about the opportunities, so looking at data and the opportunities. It's also been looking at the levers that the group has. So remember, this is supporting the group. It's slightly, you know, it can come across as a bit internally looking, but how do we help the group play their part? So we need to understand what levers the group has got as a collective, and they're different between different organisations. So we've been talking about, well, what are the levers and getting a shared understanding of that. And then we've also been looking at, we did a commission around health and all policies to get the evidence base about a year and a half ago, to look at, well, what is best practice? What does this mean? How do we do it? But we now, that forum, I hope, will help us tease out, well, what are the kind of development needs that each of those group organisations has, and what's the most practical way that we as a very small strategic unit can work with them, help them to enact that, take that forward.
Thanks. And my final question that really is quite a personal one for you, Vicky, in terms of how you're going to avoid conflict in almost double hatting, for want of a better term here, and whether in particular you had any consideration as to whether you should have taken on a role kind of close to how the chair of this committee will, as an observing member, or what was your thinking and how you would operate this role and how you're going to avoid conflict?
So part of the modelling of this role was on how would you operate as a Director of Public Health in a council. So as Director of Public Health in the council, your key accountability is to your population. Yeah, that's ultimately your key professional kind of accountability, and to the council and the democratic processes that operate in that council. And it would be the same within the GLA. We also looked at the fact that my role is linked to the Office of Health Improvement and Disparities. So the Act talks about the most senior person in public health as London, and public health as being the statutory advisor to the Mayor, the GLA and the group. So that's set out in the legislation, that expectation. And then my professional registration, there are lots of standards in there around probity and how you function. And my professional registration is dependent on that. I'd also have access to legal advice, you know, given the fact this is looking in the same ways we took that in setting up the forum, you know, quite detailed from a public law perspective around where accountabilities sit, how decisions are made, you know, based on the legal status of each of the group organisations. So I would hope that if people had concerns, they'd be able to raise them with me. I'm not actually employed by any of the group. I'm employed by the Office of Health Improvement and Disparities under the Civil Service Code. And that I hope within that role and with Kevin and the legal team, we'll be able to kind of work through any of those kind of potential issues of conflict.
Thank you. At this stage, I'm going to insert a comfort break, so hopefully everyone will be able to be back here at 11:20.
hence we couldn't start.
Thank you all. I hope you used your comfort break well. I should also say that we have in the building, and they may be due here to visit the Manor Longbridge School, and I think they're here. That's brilliant timing. So we'll let them settle, I think, for a couple of minutes. No, they're still waiting. So let's move on to our questioning, and we can say hi to them and give them a bit of a wave in a chair. Hopefully, nothing too extravagant. I'm going to turn to Assembly Member Russell for the next couple of questions.
Thank you, Chair. So these questions are for Will and Farrah, and it's about. So the first question is, prior to establishing the GLA Group Public Health Unit, how did MOPAC work with the GLA to embed a health in all policies approach, and what was the impact of this work?
So the impact prior to the So I'll do my best on this one, Assemblymember Russell. Obviously, my tenure at MOPAC somewhat coincides with the establishing of the Public Health Group, given I've been here about 2.5 years. So I can talk a little bit about it, but I suppose what I'd observe is that unquestionably, public health and police and crime matters are always going to be intertwined, and I think it would be remiss to say they weren't beforehand. And certainly prior to the establishment of the group, we were working with public health colleagues when I joined the organisation. However, I think we should recognise that relied a bit on sort of goodwill. And what we lacked was the sort of dedicated skills that Farrah is really bringing at the moment in terms of a proper portfolio of work. So it was somewhat ad hoc. That's not to say it wasn't impactful, but what I'd say is it lacked a sort of structured basis. So it was more on an issue-by-issue basis. So although there was obviously an enormous amount of public health input that went into the establishment of the Violence Reduction Unit, which clearly was built on a public health approach and came off the back of a summit, I believe, that was held and supported by public health colleagues and Dr. Coffey back in time. And obviously Kevin Fenton and other NHS colleagues like Martin, who's the Violence Reduction Programme lead, were clearly involved in that. And I know the committee will know all about those, particularly those that sit on the Police and Crime Committee too. So I think what there was prior to the public health unit's establishment was a clear recognition that public health approaches, and I think we mean that in its most maximalist sense, i.e. the sort of greatest preventative activity for the greatest number of people to impact on these sort of somewhat endemic issues in London, was always going to be the way forward. And I think the sort of fingerprints of that work, sorry to use fingerprints again, but I think it's probably a good analogy, were clearly there in the establishment. That has somewhat laid the groundwork for the unit coming into being today. Specifically in terms of MOPAC and the way MOPAC would work with the wider health economy, I think I touched on that a little bit earlier. Again, it would have been on an issue-by-issue basis. So particularly in terms of the sort of wider NHS, our way in would have been the specialist commissioning team, the health and justice team. That predominantly looks at commissioning issues within the justice system. So, right from sort of victims of serious sexual offences, all the way through to drugs. So a good relationship and much joint working happens there. I know we've spoken previously at other committees about things like our Stalking Threat Assessment Centre and et cetera, et cetera. So there was already good joint working. I think, though, I know you didn't ask me this question, but I'm going to say it anyway. The difference now, I suppose, is that in the new strategies that that the Mayor has launched recently, the Police and Crime Plan, the Violence Against Women and Girls strategy, you will see a public health approach within those, sort of mirroring some of the work that was done in establishing the Violence Reduction Unit, and they're refreshing their strategy at the moment as well, which will have more public health in it. So I think we can see there's specific mention in the Police and Crime Plan, and maybe later if the committee is interested, we can talk about some of the specific work that's in there. But you'll see a public health approach writ large in the Police and Crime Plan. You'll also see, really, in the opening sentence of the Violence Against Women and Girls strategy, public health approach mentioned, and I think that's sort of testament to the maturity that whilst there was clearly an impact, and I haven't mentioned the health inequalities strategy, which predates those two documents, but clearly that also has police and crime issues in. So I think we can see the journey, and I think for MOPAC that's quite clear that then that leads to a big rationale for the formation of the group and sort of dictates the work going forward. But I'm sure Farrah will want to add to my overview.
Yeah, I mean, that was a really good summary, Will. But I'd say also the other thing that where I feel we've really helped has been around helping MOPAC to think about their role within a much wider health and care system across London. So thinking about how they, how their work is impacted upon, or how they're impacted by public health teams and local authorities, OHID's work, just thinking beyond just the sort of health and justice team and thinking much further, because MOPAC's work, touches on so many areas that impact on health. And there's so much potential for cross-working and or just really taking a much more holistic approach. So trying to help them think through some of those issues and then make those connections, I think, has been really helpful.
Thank you. Chair, before I ask my next question, did you want to welcome the young people who've just come into the chamber?
Thank you, I absolutely do. So welcome to our guests from Manor Longbridge School in Barking and Dagenham. So today, just for your information, we're discussing the Public Health Unit at the GLA, and what that is. It's a group of people who are really working hard to make sure that the health needs of everyone in London of all ages is as best as it can be. So welcome to our committee today, and I hope you do find some of the discussions interesting as well. Thank you.
Yes, so going back to talking about policing and health, there's one issue that has been of great concern to this committee, which is drug harm reduction. And it's very good to see that the Drugs Commission that we thought was going to be working throughout 2022 has now published its full list of commissioners, and there is now a website, and we're waiting to see when the engagement with Londoners opens. They've flagged that there is going to be some discussion. But interestingly, the new Metropolitan Police Commissioner has been very positive about drug diversion approaches. So rather than putting people who are who get, through stop and search or whatever, found with small quantities of drugs like cannabis, putting them into a diversion approach which educates them about drug harm and doesn't mean that they get criminalised and put into the criminal justice system, with all the implications for their well-being that come after that. So I wonder, given that we now have a commissioner who seems to be very open to those kind of public health-based informed approaches to policing, do you see any? Do you see MOPAC? Are there any changes that you're seeing coming down the tracks that we need to be looking out for?
Yeah, thanks. I think yes is the obvious answer. So there's also a bit of legislation here, which is the new two-tier framework for out-of-court disposal. So there are changes to the way the police are going to deal with things outside of court and the criminal justice system, and those are coming into force next year. And MOPAC is working very closely with the MPS on the implementation of that. And specifically, we're looking at the partnership approach. So clearly, if we're going to divert people, we're going to need some commission provision for them to go into. We're going to need, mechanisms of doing that. We're working really closely with the London Heads of Community Safety on this, because boroughs obviously have an incredibly important role to play. So it is likely, and you're absolutely right, it's brilliant that the Commissioner supports these approaches. In fact, it's a big part of his strategy. Your Assembly members will be aware at Police and Crime Committee, the Commissioner has sort of opined his priorities and how he's going to do that. Less crime, more trust, and higher standards. So clearly, diversion is a big part of that. Drug diversion itself is being looked at in the round as well by the aforementioned Commission. and it also is being looked at by the new London Drugs Forum, which is a jointly chaired group by the Deputy Mayor for Police and Crime and Dr. Coffey. And it was a topic of conversation at the first meeting of that group, which was a few weeks ago, jointly sponsored by the Public Health
Forum.
Unit. The London Drugs Forum, yes. So the Drugs Forum.
So who's on the Drugs Forum? I'm not sure that.
Yes, I can tell you that. Actually, my colleague Kenny attends that one, but Farrah does as well. Farrah, tell us about it.
Sure, it's bringing together both strategic enforcement and health representatives. So thinking about sort of ADPH representation, people representing heads of community safety, there's police there, we've got a sort of mental health clinical specialist there, we've got a big range of stakeholders, senior stakeholders from both enforcement and health, thinking about how we as London approach drugs. So you may know the government's drug strategy from harm to hope requires each local area to set up their local combating drugs partnership. So potentially we could have 33 separate, needs assessments and approaches across London. So so working with MOPAC and the GLA, we thought it would be a good idea to, and OHID as well, thinking to convene some of these sort of senior stakeholders and think about what is it worth thinking about on a regional basis. Our needs assessments, things like county lines and city lines of those issues that touch on both health and harm, which are across London. You can't just take a single borough approach to some of those things. So we've been convening this.
That
group.
sounds incredibly positive.
Just one. Farrah, can you just turn your microphone so it's closer towards you so that.
Sorry.
Perfect.
Yes, that sounds incredibly positive, very welcome. Are the notes from those meetings, are the minutes from those meetings published? Is there any way for us to learn about what happens in those meetings or what's discussed?
So because whether they're dealing with sort of police or operational issues, I don't think those minutes are in the public domain. But Will, do you don't?
Can I get back to you on that one, Senator Russell? I think Farrah's probably right, because there are operational issues in there. It may be, but let me talk to my private office when I get back to base.
That would be fantastic, because I think it's something certainly on this committee we're incredibly interested in, but also on the Police and Crime Committee. Yes, it's great to learn that this forum is happening, and it sounds like a really important piece of work that it's doing, and it would be good to understand at what point we can be told about what's coming out of that piece of work. My final question is about the engagement that MOPAC has had with the Public Health Unit since it was established, how the establishment So what's happened since? Is there anything you want to add? Because you've actually been sharing quite a lot on this already. But is there anything you want to add about the way that you're working with the Public Health Unit since it was established?
Yeah, absolutely. I mean, I mentioned those strategies, and I won't bore Assembly members with them again. But they are our key documents. An area probably we haven't spoken about too much at the moment is mental health, and there are sort of two key domains for mental health, if you like. One of those, obviously, and going back to the Commissioner and the Police and Crime Committee, is as part of the plan he's got to deliver those three high-profile headline activities is mental health, and one of the challenges that he's seeing that officers are experiencing is that when working with members of the public who are experiencing a mental health crisis, officers often take those people to A&Es. We know there are pressures in A&Es, but officers can end up spending quite a lot of time with them. The reason I mention that is Farrah was in a meeting last night with the MPS representatives, and I wonder, do you want to tell us a bit about the progress made?
So it's a very complex area. As you can imagine, there are issues in A&E in terms of the sort of health service capacity to take on patients. There are issues with the Metropolitan Police, how they how they sort of are trained to recognise someone is in a mental health crisis and needs to go on that pathway, and potentially also sort of call handlers as well that divert police officers towards incidents, and then in terms of the processes in the hospitals as well. So it's a hugely complex pathway to unpick, but it was really useful to speak to the MPS about, you know, what are the issues they're facing, what might be some solutions we can talk about, how can we think about partnership working with the NHS, what other issues do we need to think about in terms of the MPS getting its own house in order, how can MOPAC help in terms of its role as a funder. So it's a really complex and nitty gritty area, and there are things that need to be unknitted. But I think, you know, taking a public health approach can be really helpful because, you know, starting with the data and the evidence, you know, what can we say about what's going on, where can we see patterns, where are hotspots, where are sort of geographical problems, how can we sort of use the data to form a picture of what's going on and then tackle it quite systematically. So I think that was, you know, it was a really useful meeting, as Will said. It was our first meeting, so very early days, but yeah.
And that was a meeting between MOPAC and the MPS?
Yes, and me, yeah.
And you. So you from a health perspective.
Public health.
Yeah, so I think a really good example of how we can use City Hall and the Public Health Unit to support the new commissioner and the MPS. I think there's a couple of other areas. Caroline, do you want to indulge me, or shall I?
I'll indulge you. Yes, please. If they relate to health, because we're in the health committee.
Yeah, no, they absolutely do. I mean, the other thing I just wanted to mention was offender management. So there's two key areas of, and then I'll touch briefly on violence against women and girls, if that's okay. But integrated offender management is obviously quite a big role that MOPAC plays in terms of coordinating and using our convening power around integrated offender management. And there are two areas where we've made real progress with the support of public health recently. The first one is back to drugs, actually, and MOPAC's funding a criminal justice and substance misuse coordinator. But where we want this is, rather than in that specialist commissioning area I mentioned earlier, we want to be able to influence local health and wellbeing boards in individual boroughs, and of course, you know, the answer to everything is ICSs at the moment and ISBs, but we want to be able to influence those too. So what public health has done really well is sort of brokering that relationship, so that as that role comes into place, people will understand. And there's a lot of work that goes on with the ADPH, which Vicky used to pay, but all the public health. So it's the Association of Directors of Public Health.
Yeah.
Beg your pardon, which Vicky used to chair in a former life, but is a brilliant group. So there's a lot of brokering of this because we want this person to land well, so we can have the biggest impact we can. At the moment, I think offender management isn't something which gets a lot of an airing at health and wellbeing boards. But yet, obviously, these are people with some of the most acute health issues, and from a public health standpoint, clearly that's quite causal. The other area with offenders is mental health. We're actually co-commissioning. I know I've mentioned this at Police and Crime Committee, but we're co-commissioning a mental health service with probation as part of our integrated offender management, and again, public health have been helping with that. The last area I'd just highlight, which is a huge one actually, is as part of our violence against women and girls strategy, or rather the Mayor's violence against women and girls strategy, we're really keen for the NHS to adopt a kind of London-wide approach or set of principles to tackling violence against women and girls. We know the NHS is a big and complex beast, you know, with competing geographies and different areas. Tomorrow, the Deputy Mayor is speaking at a NHS-wide violence against women and girls conference. She's a keynote speaker. It's a key sponsor. It's a co-sponsored event between NHS and MOPAC. It's absolutely brilliant. That wouldn't have happened without the help and support and brokerage of colleagues in the Public Health Unit. And that'll lead, hopefully, to a summit in the new year where NHS organisations will make some quite specific commitments, we hope, around tackling violence against women and girls. I think that's a brilliant example of what Farrah was saying earlier about MOPAC seeing itself as part of a broader system and reaching out. I think if we can achieve that, that would be an incredible sort of impact, but also evidence of the joint working between our two units.
Thank you very much, and it is so good to hear about these actual practical examples of the way that this, this kind of public health in all policies is properly getting out into with the right people coming together. So thank you, and I'll hand back to you, Chair.
Thank you, and I see our friends are leaving, so I hope you've enjoyed your visit around the building as well. Thank you very much for attending. Assemblymember Best.
Yeah, just thank you really quickly, Chair. Coming back to drugs, and Assemblymember Russell mentioned our focus on this in this committee. So we actually produced a report last year, the Reducing Drug Deaths in London. I wonder if, as part of the London Drugs Forum work, if they could review that report and let us know their feedback to those recommendations.
Absolutely, I think that sounds very sensible. I mean, some of the topics were already discussed. Actually, I know naloxone was one that was discussed at the forum. Sorry, Farrah, please come in.
Naloxone.
Oh dear, I'm sorry. I mean, that's made up. I'm actually a chemistry graduate, embarrassed to say. Absolutely. I'll feed that in. But rest assured that those recommendations and those topics are, some of those have already been picked up. We've only had one forum. Absolutely.
Great. That's reassuring, I think, from all of us on the committee. I'll turn to Assemblymember Andrew Boff now.
I picked the wrong time because I'm going to talk about playgrounds, and that might have been quite entertaining. But before I get on to playgrounds, can I just ask Ms. Hobart, in your presentation, you've indicated that the new public health unit will be a service to other areas. Should you be a police officer as well, in terms that are we going to see situations where policies are being developed without the input of the public health unit, or are we just waiting for them to ask?
So the governance for each of those organisations is their governance. They have their decision making, they have their legal requirements for consultation, etc., etc. I think this goes back to how we prioritise, and I guess from my unit's perspective, our task is to be relentlessly focused on where the public health benefits and gain sits. Where can we have the biggest impact? So to operate strategically, we need to be in that space of helping and advising on where are the biggest health gaps, what is it that can be prevented, how can we support Londoners' health, and that includes resilience. So sometimes that is being timely. So during COVID, most of our resource was reoriented around COVID and COVID response, rather than strategic work around a whole range of different kind of public health opportunities. Yeah.
That's where your focus will be now, about all the policies that the Mayor is
So my task will be helping, as I see it, to balance between immediate and urgent and the strategic responsibilities of the authority and the group.
Do you see overcrowding in public housing as a public health emergency?
So we've just been working with the Institute of Health Equity to produce the evidence report on a range of issues. The first one that they've published is on health and housing, which pulls out a range of pressures, including overcrowding, including the cost to Londoners of housing, impacts there on child poverty, but also including 1 in 5 excess deaths being related to cold. So when we say, and I think it's quite rich and helpful for us in thinking through and quantifying those public health impacts, but also where there's opportunity to act.
So when policies are being developed, and I'm thinking particularly, it'll be no surprise to you, about the typology of buildings, and there are some typologies of buildings that are healthier than others. Do you think you're going to be involved in the future London plan? And you did say that London plan will be one of those things you'll feed into. Do you think you'll be involved in the decisions about building typologies on a public health basis?
So the public health evidence needs to feed into strategy making, and the statutory strategies of the GLA will be our key documents. Now, obviously, it's been a while since, they were developed in the previous mayoral term. Getting that evidence base ready would be a key function for my unit. And that housing product was one element of that.
So
having that there and pulled
so
out.
you would seek evidence about the relative merits, the relative health of different typologies, and then feed that into the unit. Is that correct? Feed that into.
So we would work. So I have a portfolio holder that works on housing, and they interact with the housing team, but also the wider public health system, and other GLA teams. And the task is going to be, as the strategies are developed or policies are developed, to make sure that evidence base is there and present. Most of the statutory strategies have a legal responsibility around an integrated impact assessment. So that input and evidence is not just coming from the public health unit. There's a legal responsibility to consult, and I think the integrated impact assessment process, that is where that evidence is brought together, to kind of test a strategy. So we might be inputting evidence. The idea is we'll gather evidence, we'll input into strategy and policy making, we'll also support the integrated impact assessment that's kind of testing that. And that needs to be really, really robust, doesn't it? That integrated impact assessment of the draft proposals is a really important process.
And just to go back to what I said before, the accessible play space has to be a public health issue, is that correct? You're nodding, but is that correct? Do you think the accessible play space is important?
Accessible play spaces.
Is
access to green and
people.
open space, is as a priority within the health and equality strategy.
Thank you for that. Perhaps you could also tell me how the new unit will support the delivery of the health inequalities strategy, and how it's intended to improve and build on the work under the previous structure.
So, lots of involvement in developing and writing the health and equality strategy, and the regional director of public health, so was Yvonne Doyle at the time it was adopted, is now currently Professor Fenton, playing a key role as the Mayor's statutory advisor around evidence base. So I guess wearing my OHID hat, making sure that we have access to and good relationships with national government about policy and strategy as it relates to health and equalities, as well as local public health teams. In practice, what it means at the moment is my unit work very, very closely with Jazz's unit, particularly the health and equalities team that oversee the strategy, that report on it on an annual basis, that work with yourselves and the committee around the health and equality strategy, sometimes to help where GLA Group organisations are taking forward key commitments. So the Mayor's made a number of key commitments. Some of those are delivered by different group organisations. So we're supporting in that way. But we're also supporting in, as I say, the element of understanding how health inequalities are changing in the city and what are those opportunities to intervene. And the Institute of Health Equity project would be an example of that, pulling out that evidence base post-COVID around where are those opportunities to intervene.
One of those opportunities you're looking at the moment, I believe, is covers gambling. And I wondered if this is going to lead to a ban on advertising gambling on the tube, like we saw on obesity.
So there was a manifesto commitment around gambling. There was the health and care devolution deal back in 2017 for London, signalled that London wanted to do work on reducing gambling harms. At that time, particularly fixed odds betting terminals, but as well as harmful advertising in the round. And certainly my unit, and it's what's been excited again about having registrars, have commissioned some work from academic partners looking at gambling harm and how that relates to exposure to advertising, that's helping to create the some of the evidence base around that.
Okay. I'll tell you what one of my concerns is that previous time when you were in front of us and your previous guys, I asked you whether or not you had been involved by, you'd been called on by the planning team or any of these, some of the other teams, to actually give evidence when the mayor had last asked you to sit in the room when discussing policy. And at that time, you weren't able to come up with a time when the mayor had done that. Do you see that as happening in the future?
So if I recall correctly, it was partly around the housing strategy specifically.
That's right.
Now,
you're
the
right,
portfolios that we've set out are also part of the kind of consistency, the corporate memory around input, and the specialisation. So we have those 5 kind of broad portfolio areas now to provide some of that kind of consistency across. In my previous role, I was, as head of health, was overseeing a wider range of work. Part of the point of setting up this unit is to have and be able to collate that evidence base more consistently and with better kind of corporate memory around those inputs.
I mean, on the whole, setting up the unit seems a good idea. But and what's the policy areas currently across the GLA group that you're prioritising?
So we have one sec. So the first forum meeting gave a good opportunity. The line we've been taking is there are existing commitments and resilience work that we're already committed and doing. We have been focusing on bringing in the team, and we've been in conversation with group organisations around where their priorities are. And the conversations with the deputy mayors have also helped to cement that. So on Transport for London, we've been working with them particularly around the accident prevention strategy, so Vision Zero, air quality issues, climate change adaptation, so getting ready for that, the healthy streets work, as well as starting to explore conversations about workforce health and well-being. You'll remember the impact on transport workers of COVID, what that impact around kind of poor underlying health. MOPAC, I think we've been hearing about today. Working with the fire brigade, that's probably a newer relationship. We've worked with them. They have a blue light prevention group. They'd self-organised over a number of years, bringing the ambulance service, police together, fire brigade. The fire are particularly interested in their sort of person-centred fire risk assessment processes, referrals of high-risk individuals, but also given the heat wave in the summer and the fire response, their role in kind of climate has also been something that we've been exploring with them. From an OPDC perspective, they are developing their own local plan, and they are still working through kind of infrastructure requirements for that whole kind of development site. So the relationship with the NHS and social care colleagues in the patch being important to them, and then ensuring that their local plan really embeds health and well-being in the plan as it's developed.
I mean, you've got a number of priorities. It's not a very big team you've got for that breadth. Far be it from me to say, as a Tory, that haven't got enough people. But it does seem like quite a lot of responsibility for what's quite a smallish team, or efficient team. Are you going to be able to put up? Are you going to be able to meet the demands that are going to be put upon you?
So the unit in and of itself will not be able to. We need to work with the wider public health system. The step change here is having some policy and programme capacity specifically for this. So there's 4 new roles. 2 of them are business coordination and programme coordination, which will help with work planning and business planning. And the other 2 roles are grade 8 roles, really important around policy and strategy development that can actually take forward some of the technical work. In the mayoral decision, it talked about creating a 5th public health consultant post. And we went through, as I've described, the sprint process with these organisations, and this was the kind of minimal viable product, if you like. So we will be looking at, and there isn't a big programme budget to commission out work, So if there are big chunky pieces of work that organisations need doing, or there is a judgment that these things need doing, we would be working with the various organisations in the shared service to carve out resource to take some of that forward.
I mean, and finally, Chair, before I hand back to you, if I can go back to the Mayor had said that despite the experiences that we've had during COVID, despite the evidence that the Planning Committee, for example, had established about the health of tall buildings, that he wasn't particularly interested in reviewing his health strategy. Is that something that you could persuade him to do?
We are, the organisations are under the political direction of the Mayor. He will take evidence from a whole range of places, and we'll play our part in providing that public health evidence.
I kind of knew the answer to the question I asked. Thank you very much.
Thank you. Assemblymember Bessie, do you want to come in still, or?
Yeah, thanks. Sorry, I thought that was later, so I wasn't quite prepared, but I'll try and find it. Just quickly, Vicky, I was interested because it was before my time. When the junk food ad ban came in, which university was commissioned for that study?
So the evaluation...
Not the evaluation, sorry, that was in my time, so I hope I can remember that. The evaluation of it when you were commissioning the study to look at bringing it in.
So the evidence base for food advertising was very extensive. The policy context for that was very different. There'd been the Great Weight debate in London with Londoners already. There had been a range of work being taken forward by councils. It was in the Health and Care Devolution Agreement, so it was the policy context was very different, what I would say. The nutrient profile model already existed because of television advertising. So the case for action in that area and the evidence base was already there. What there wasn't the evidence base on was the impact of out-of-home advertising. So the independent evaluation was something that was not commissioned by the GLA. That was funded through the National Institute of Health Research. So the gap, if you like, in policy making there was more about out-of-home advertising. It wasn't about the principle of advertising having an impact.
I think that those that have been long-term campaigners for gambling awareness and especially on gambling ad bans would probably contradict that statement, that there is quite a wealth of information there. I just wonder, because it's taken, when you look at these two issues, one, it seems, was enacted really quickly, and the other one not so. And now we're commissioning out to 2 universities for further studies when there is already quite a wealth of information and reports and evidence base out there.
So when again, in terms of the role of my unit, looking at gambling related, how many people gamble, gambling related harm, what's the evidence on out-of-home gambling advertising, that was the commission, was to pull that together. As I say, this has been in the context of the unit also being very focused on COVID in the past 2.5 years.
Thanks. And I wanted to come to you, Farrah, if I could. In your role, obviously, one of your remits is looking at reducing HIV. Now, last year, the Mayor agreed in a question to me when we were talking about advertisements on TfL to help with partnering up with Terence Higgins to run a ad campaign to promote HIV testing. And then subsequently, after that public statement agreeing he would do that, he did rescind on that offer. In your role now, is that something that you can push for and try and work with the Mayor to make sure we do get that campaign, which will obviously be of great benefits, especially targeted at some of those boroughs that we know have the most undiagnosed cases out of the whole of the UK?
So across London, there is an HIV prevention campaign called Do It London, and that is funded by all the local boroughs in London, and they sort of put contributions into that, and that is sort of rolled out across London, particularly targeted at those boroughs where there's high prevalence and particularly high undiagnosed prevalence. So there is quite a lot going on in this space already. So I'm not sure, if I can sort of, but yeah, I don't know if there's additional value to be added from sort of additional advertising, because this campaign is already in place and it's very excellent. It's been evaluated as being very effective.
It concerns me slightly that you're in your role as reducing HIV, and you should surely be the advocate for doing so. And I mean, when we're the advocates for doing so and the champion, we think about one thing. Maybe others shoot us down and say it's not possible. But you're saying you don't think there would be value in running a campaign to promote testing on the TfL estate.
I'm saying there's already a campaign that promotes testing, which is on the TfL estate, and also it's not. Advertising is not the only way in which you reduce HIV. There are so many other sort of mechanisms in place around testing, around relationships, around stigma, around the partnerships.
I agree, but it's about getting that free TfL advertising to give that space to I'm talking about growing that and using perhaps a large body such as Terence Higgins or charity to partner up with the established groups working for those boroughs to give them the free space to ensure that it's really, really prominent.
Sure. So, as I said, there is already a campaign which is on TfL, but I don't know if I can influence that further, not being sort of directly linked to TfL, the advertising side of things.
Thank you, Assemblymember Best. It's worth looking into actually, because so in my previous role as a borough lead on public health, I was involved in a Do It London campaign as well, so I know Terence Higgins Trust are involved in that as well, so it's just about the messaging, and every year they work to look at which messages work. And I know it's used on TfL estate, but I think that the point about what is it being provided at cost, free, etc., how they're being supported wider for the community messaging, I think it's something that we can definitely take forward and just see and just do further inquiries on that, especially with World AIDS Day also coming up soon over the next couple of weeks. So thank you for raising that issue in particular. My question next is to Vicky. So in terms of reviewing and looking into the future and taking the learnings from the unit as well. So what processes and timescales are in place to review the impact of the unit and assess whether it's delivering against its original aims, or indeed whether the original aims were, work out to be the aims that you would have, that are relevant going forward, and whether you need to change them as well?
Thank you, Chair. So going into next financial year, will be the first time we'll have a business plan with the benefit of input from the forum, and having been set up, with a team and people in post to actually do as well some of the work around reviewing priorities. So our business plan for next year will be important. It will still be closely aligned with the Health, Children and Young Londoners unit, but that will be an important moment for us. This project was sponsored by the GLA Collaboration Board, which meets regularly. It's sponsoring and championing a whole range of projects that are looking at better value for Londoners through the work of the group. So we still report to them on benefits realisation. And the forum meeting, so we have a forum meeting in February, which will be quite instrumental in helping to shake down some of the priorities, and a meeting scheduled for May, which will be looking at in set-up mode, for, as I say, for that first sort of financial year when we've actually got the team in place and the value, and some reflections on kind of what's worked, what hasn't worked in the first year.
Okay, so post-financial year is when you'll be reviewing as such. But because what I'm getting from your answer is there's continuous reviewing, but is there a point where you just step back and review the whole picture?
Yes, and the forum will help us do that in February. The collaboration board helps us do that through their benefits realisation process for the whole board. In terms of where their public health gain is, as I said, we're working with the Marmot team at the moment on evidence reviews, but we've also been going back to the data, and it's a moving feast, isn't it? The census was undertaken in 2021. We're still uncovering and understanding what that means about London's population now. And we know that both the pandemic and cost of living are impacting on Londoners' health, and that has some unknown unforeseen or difficult to quantify implications. So we will have a product that we'll be able to share soon around that's looking at health inequalities now, sets out what we know. But I don't think we're looking at, the planning context is not very, very, very stable that would enable you to say if we do these three things, we're going to have this level of impact on population health. So we will have to maintain a level of agility in the way that we've done over the last 6 months around things like heat wave, monkeypox, polio, etc. Yeah, that enable us to support the group in what they're dealing with. Yeah.
Okay. No, that's fair. And then to Will and Farrah. So, what areas would you like the public health unit to prioritise in the future when providing public health support and advice to MOPAC?
Well, this is nice, isn't it? I get to, I get to set Vicky's business plan for next year. No, I mean, in all fairness, I think the areas continue to be actually the right ones. So, for us, it's violence against women and girls, which is a big priority. So we've got the work we're doing on the NHS, but there's also more places we need to go, particularly in the prevention space, and having public health input and support, both in terms of evidence, but also stakeholders, can be really crucial to that. We've mentioned drugs. Clearly, there's an ongoing work on drugs. We'll move into the next steps on that, which will be interesting and exciting. Mental health, I know I've mentioned that both in terms of offenders, but also in terms of victims, particularly actually sexual violence victims. We support a lot of those through MOPAC commissioned services. There's a lot of strain on mental health services in London at the moment. I'm sure the committees are more than aware of that. So that's another area where we want to do some more work. Child sexual exploitation and abuse is another area that we'll be doing more work on next year together. And the last one is more broadly sort of victims of crime, full stop. We've got quite a comprehensive needs assessment on victims in London. There are many crossovers into public health. I think we know that for particular crime types, and particularly for young people, there's sort of underreporting as well. So again, it's an area where that sort of public health approach, that maximalist approach, is going to be one that gives us the greatest benefit for Londoners. So those will be our areas. I hope Farrah, you recognise those.
Yeah. If Farrah wants to come in first, and then Emma has a follow-up, anything else to add?
I'm completely in agreement with Will. Yeah.
Assembly Member Best.
Thank you. And I just wanted to state it for the record more than anything, because Farrah hadn't really realised you were going to contribute. So I just wanted to make clear from this is the Mayor's response to me on HIV advertising in relation to Do It London. And this is from the Mayor in response to me. It said, I am not in a position to offer further advertising space for free at this time, as the Greater London Authority has very limited advertising space and it is already scheduled for this year. So I just wanted to make sure that you're clear that this year they aren't getting that advertising space.
Not for free. Okay.
Yeah.
I just wanted to make sure we're clarified on that point.
Okay, thank you.
Okay, great. And next one is actually a final question from the committee. So it's to Vicky and Jazz. So how will you know if the public health unit has been successful in 12 months' time, and what tangible changes will be visible by this point as a result of its work?
Thank you. I suppose from my point of view, as being part of the kind of representing a team within the GLA group, I think I suppose I'm probably a bit like Will in that I kind of got a fair idea of what I'm looking for out of the unit, I suppose, and the totality of my unit's function and the work that I'm doing would really benefit. So knowing where I'm getting resource from, we have a long-term trajectory plan that takes much more of a public health approach to delivering the outcomes we're wanting to deliver. So in addition to health, we're also delivering the New Deal for Young Londoners young people mission, and a big aspect of that is how do we improve the well-being and the health outcomes of young Londoners, and some of that will be about how they're able, in fact it is Farrah that's kind of supporting us in some of those areas of work as well, to think about how we're helping young Londoners through having better access to opportunities and through having access to mentoring. Are we maximising the opportunity to improve their well-being? That's the kind of, and the long-term ongoing plan that we need to be having around those areas of work, I can feel confident has a good public health approach to it. So that for me would be an example of what I think the kind of the wider outcome would be. I think there is something also around the kind of working together with Vicky's unit, the kind of wider interaction of the health and care system in some of those wider, those bigger priorities that we have. So in the way that we'll describe, it's kind of how are we seen as part of the health and care partnership for London, but also how are those partners, how is the NHS, for example, seen as a partner to us in some of the wider priorities that we have that are also beyond health. So how is the NHS or the local government seeing themselves as partners in reducing crime and supporting public confidence? So those are the sorts of, how do we grow that mutual relationship with the wider system? That's an example of what I'd be looking for.
Okay, and Vicky, do you have anything else to add on that?
Yeah, I mean, in a year's time, I'd like to look at those population health outcomes either starting to face in the right direction, those gaps narrowing, or at least the plan and the understanding of how we can lean into them and narrow them being clearer, and what the GLA Group's contribution is to that and could be to that. On the other end of the spectrum, and I'm asking this exact question to my new team on Monday when we're getting together for the first time, is how they, as a number of people working in a team, what their individual contributions are, how they can quickly understand how the GLA and the GLA Group works, and that's going to be a journey. It's not intuitive, as I say. We don't have a blueprint to look at of how has this worked in another organisation, and the GLA Group is a complex beast. So at the top level, I want to be clear on the outcomes and what the plans are to lean in and improve them. But on the other end of the spectrum is literally mobilising a new team to work most effectively. And a lot of this year is going to be delivering those existing commitments, staying resilient around whatever life may throw at us, and getting a group of people that are solid and resilient in themselves to want to stay and do the job and develop this function going forward.
Great. Well, at that point, I'd like to thank all of our guests for your contributions today, and our visitors who were here with us as well, and anyone who's joined and watching at home as well as my fellow committee members and the staff that have been supporting the committee today. Can we note the report and today's discussion?
Noted.
Can we also delegate authority to me as chair in consultation with party group lead members to agree any outputs from the discussion?
Agreed.
Right, and can we note our work programme?
Noted.
And can we delegate authority to me as chair following consultation with party group lead members for the site visit to happen in the first place, but also to agree any output arising from our upcoming visit with the London Ambulance Service?
Agreed.
Thank you. And the date of our next meeting of the committee is scheduled for the 2nd of March 2023 at 10 a.m. here in the chamber. And in between then, that's when we'll have the site visit before that, which seems quite strange because this is the last meeting before Christmas and the New Year. So as this is the Health Committee, enjoy yourselves in moderation, of course. I have no other urgent business, and I therefore declare this meeting to be closed.